Hey everybody, Tom Judd, IFMB CED, and privileged to be part of the Founders Council for the Global Clinical Engineering Alliance, GCEA. And I got with me Dr. Jim Weir today, and also a member of the Founders Council. So Jim, tell us about that history you have in clinical engineering. It's been a while, brother.
Well, I came about it from a very different way than most people. Number one, I got a bachelor's degree in chemistry in 1959 from the University of Arkansas. Got a master's degree in 1960, finished up my PhD in the summer of 1961, and went to Sandia Corporation in Albuquerque, New Mexico, as a research chemist and an in-house consultant in the nuclear weapons and space safety program. Fortunately, in 1965, I saw a blind ad for a research position, what turned out to be at the VA Medical Center in Little Rock, Arkansas. And so it gave me a chance to come back to Arkansas, where I worked in nuclear medicine, as well as supporting research in the VA in the southeast part of the United States, which is basically 1/4 of the United States. Somewhere about that time, Congress said that the VA had millions of dollars of unused research equipment. That's in 1966. And our center was asked to develop a program to solve this. So I ended up developing a program to move medical equipment between research programs and to get it where people would know about it. Because unfortunately, as medical doctors move from hospital to hospital, the research interest at a given hospital changes. And so as a result, there was equipment setting idle, but it was nowhere near what Congress thought it was. And as a result of that, I got to know a lot of people personally in VA headquarters. In January 1969, I presented a presentation in Boston at a meeting of physicians and engineers sponsored by the Quality Control Society. The VA had been asked to make a presentation of its maintenance of medical equipment. And due to my connections with central office, I was asked to collect the information, make the presentation. Well, I found that we had no maintenance program. And at that meeting, I got involved with the start of AMI. I met Dr. Dave Simmons and got also involved with people developing a curriculum for BMET training. As a result of that meeting, I ended up writing a chapter in Dave's first book on clinical engineering. In 1970, an industrial engineer in VA Central Office Engineering got the medical department of Central Office to establish a committee to look at medical equipment maintenance. Well, this committee consisted of 3 hospital directors, a supply director, myself, and the industrial engineer. First time we met, the hospital engineers assured us, the hospital directors assured us that they had no problems. We told them to go back and look for a few things. The next meeting, they came back and thought the problem was worse than we thought it was. So the industrial engineer and I wrote to the Republic a report with a recommendation to establish what we called a biomedical engineering program in central office, and hire biomedical engineers and develop a national training program for BMETs and biomedical engineers. I was offered to head the program in central office, and I turned it down and recommended that Dave Simmons be hired. I wasn't interested in moving from Arkansas to Washington, D.C. I added the training program at my medical research equipment distribution program. All of this started in 1972. I also got involved in the establishment of the BMET training program at what is now Texas State Technical College in Waco, Texas. Again, I'd met a person at that meeting in Boston who was interested in this, and we got together and we developed the program that was done there. And this also was the time that I got involved with AMI into the development of certification of BMETs, and I was on the first board of examiners for that. Well, with the VA training program, I got VA education money and developed a resident and teleconference and correspondence training for VA biomedical engineering technicians, biomedical engineers at the North Little Rock VA Medical Center. Not far from my home, of course. And as we brought medical research equipment in through our relocation medical research program, we used some of that equipment for training for the technicians. And of course, had to train existing people that were working on medical equipment who turned out to be plumbers, electricians, and other kind of technicians. We couldn't very well get rid of them and hire BMETs. So we ended up doing that. As a result, I had VA leadership positions in medical research, VA education, and VA engineering. That means I had 3 bosses in central office. But that was not too bad. As long as I kept 2 of them pleased, I was in good shape. About this time, the University of Arkansas for Medical Sciences developed a College of Health-Related Professions, and our VMET program became a part of that program, and I became a department chairman as well as a professor. Had no payment, of course, since the VA was paying my salary. At the same time, I also was a professor at Philander Smith College, which is a predominantly Black university, teaching various courses in science kind of thing. I did that before I went to work for the VA every morning. And the VA supported this total development of the allied health program at the university. Unfortunately, our BMET training program at the university was started in 1972. We discontinued the program in 1997 because of lack of students. We had trained all the people that were working locally. Well, nowadays, they need a program again because all those people have retired. In 1974, with our general training and program, we started training hospital engineering employees. And in 1976, we added hospital safety staff to our training. That's where our training ended up, and it's still, well, it existed until I retired at least, kind of thing. I worked with Dave Simmons to develop the biomedical engineering program for the VA, and we decided to hire biomedical engineers and train them to be clinical engineers. If there was no program, and still is not a program training clinical engineering. That's a 2-year training program. Fortunately, all of the VA hospital engineers are degreed engineers, and most of them are PEs. So the biomedical engineers worked for the hospital engineer, and that's where they got a lot of their management training. Dave and I became friends with Cesar Caceres about the time that he developed the terminology of clinical engineering and its relation to patient care. And this is kind of how I got into the clinical engineering area. I became certified in 1975. We're the first people that became certified based on credentials. I served on the Board of Examiners for Clinical Engineering from 1984 to 1980 to 1984, and again with the current program from 2002 to 2005. With Dr. Dave Simmons, I helped develop the clinical engineering program for the American Society for Hospital Engineering and made presentations in clinical engineering programs around the country. I've worked with the American College of Clinical Engineering and WHO in the advanced clinical engineering workshops that done at various places in the world. And I've helped to develop and promote certification of clinical engineers and BMETs around the world, especially with the IFMB CED division. So that's basically how I got into the area of clinical engineering. Tom?
Jim, it's really fun to hear about your journey and the 60 years of contribution you've made to our profession. So how would you define clinical engineering? What do you think its main activities are?
Well, clinical engineering to me is probably, my view is different than most people. I wrote a chapter for Cesar Caceres in 1977, and which was the functions of hospital clinical engineers. I made a presentation about 6 years ago at some meeting, and realistically, what I said then was pretty much what I said in a book in 1977. I think the clinical engineer is what I would call a new Renaissance man. I think the clinical engineers need to be, need a a knowledge of engineering discipline. They also need to be managers. They need to know a little bit about all kinds of engineering. You know, they come from different areas of mostly probably an electronic background, but they need to know about mechanical engineering. They need to know about quality control. They need to know about IT. You know, they need to know about maintenance and repair, although generally that's not what they do. They get involved in new equipment procurement. So they need to know what is happening in the hospital setting or in dealing with patient care, you know, and what might the future might be. And I looked at that one time, looking at where the future was going. In fact, at that time, I projected for 2020, and I'm about 50% right, I guess, kind of thing. And I made a projection for 2050, which we'll wait and see what happens by that point in time. But I think, you know, again, what I find now, clinical engineers also need to know some of the stuff that I learned as a chemist, kind of thing. They need to particularly know about patient safety, and this is a major thing. And you look at patient safety, a lot of people, I consider a hospital engineer as he has clinical engineering work as well, as he looks at the facility kind of thing. In fact, we trained our engineers in the VA in construction and development of projects. And, you know, one of the things, even if you talk about moving people, patients in a disaster, it's an engineering function. And I think clinical engineers need to be involved in that as well. They need to be involved in training. They need to be looking at, besides procurement of equipment, some of them are looked at the development and modification of equipment. They really need to know what happens with patient care and everything, and need to be working closely. And this is, of course, what Cesar Castor said. He was talking about engineers that were working with the healthcare providers and knowing what they were doing, kind of thing. They also need to know about administration. And we found that some of our clinical engineers, well, we ended up with two things. VA clinical engineers, some of them became hospital engineers because they paid more money, for one thing. Some of them actually became hospital administrators. And it was kind of interesting, though, we found that the female clinical engineers, when we hired some of those ended up, in fact, several of them went on and became physicians. You know, so I think, you know, we've looked at that the clinical engineer needs to be involved in everything with the patient care setting, and that includes the facility as well as what happens at the bedside. That's a pretty broad comment, Tom.
Jim, in your 50 years, and of course, you've been talking about the Veterans Administration health system in the U.S. Veterans Health Administration, and what, 170 plus hospitals, and what, hundreds of clinical engineers today, and thousands of biomedical equipment technicians. So what do you see today as the main activities of clinical engineering professionals? And perhaps you've already addressed that, but any further?
I think that it comes down to being involved with patient care and patient safety. And those are two very broad terms, kind of thing. But I think that's realistic. The clinical engineer and the clinical engineering technicians need to be involved in working with the clinical staff. As I had one of our older technicians tell me one time that he thought that the technicians, at least the senior technician at a hospital, needed to make rounds every day. As he said, he drank a lot of coffee and ate a lot of cake with the nurses and such, and that he was a part of their team. And I think that's, you know, where the technicians and the engineers belong. Of course, the engineers need to be sitting at the table with the administrative people, the finance people, the physicians and nurses. One of the things I did for years, I sat on a committee at the hospital which talked about the purchase of equipment and, you know, knowing what it was going to be used for and being able to help in because these engineering functions that, you know, we can do that the clinical people may not be thinking about. There's nothing more we can ask the right questions. you know, because sometimes physicians want to come in, they went to a show and they saw something brand new. Oh, we want that. Well, then you start asking about, do we really need it? How much is it going to be used? We got a place for it. And I think this is one thing that the engineer needs to be setting at that, to be sure that you don't get a piece of equipment arrive and you don't even have a place to put it. And again, this is being day-to-day involved with the medical staff, as well as the administrative staff.
Sorry, a little noise in the background, Jim. So you've always been about capacity building, and then also measuring through certification and other processes, how, whether people can meet minimum requirements through their backgrounds and experience. So what's your vision for the Global Clinical Engineering Alliance, and why'd you join that, and where do you think we're going?
At times I wonder why I joined. Whenever you and Yadin and other people want me to do something for you, kind of thing. But anyway, and since I've been retired, from working with the system now for basically 14 years, kind of thing. But again, I think the joining the Alliance keeps me involved in the clinical engineering activities. I'm still interested in the certification because, again, I think this is, I guess I want to be sure that if I'm in the hospital and some of that equipment is being looked at, I want to know that that people that knew what they were doing helped to work with the medical staff. I think the medical staff, they have a certification type activity, and we expect that. And so I think that certification of engineers and technicians is an important factor. I think it's going to be different with different countries, and it may be registration as opposed to certification, but it's looking at what is required from the day-to-day operation of these people. And I think this is, an important factor for us. And I think this is, where I see the Alliance is looking at, I think, making the field of clinical engineering more widely known, and as a result, making people look at clinical engineering as a profession and kind of thing. And I think that's as an important aspect, and I kind of enjoy being part of it.
Jim, it was great to be with you today and to hear this wonderful history, and it's right to the present day and right to now. And thanks for your contributions, and looking forward to what we do next, brother.
Okay. Thank you very much, Tom.